Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Standard Medical Notes. So let us continue the previous topic of antihypertensive drugs. So we had discussed till calcium channel blockers. So we'll continue. So with the name of Almighty. Now coming to the beta blockers. Let us discuss the beta blockers. So you can take beta blockers. Metoprolol, which is very much commonly used, then Bisoprolol, okay, and then Atenolol. So these three are cardioselective beta blocker. Nothing but beta 1 selective blocker. Okay, and this is actually a alpha beta blocker, alpha 1 and beta 1 blocker. So what is the advantage of this? Because of its alpha 1 blocking activity, in addition to reducing the heart rate, it also causes vasodilation. Why it causes vasodilation? Because the alpha 1 receptor causes vasoconstriction. So anything which blocks alpha 1 receptor causes vasodilation. So it is a vasodilatory. So Carvedilol is a vasodilatory beta blocker. So these are more commonly used in cardiac patients, vasodilatory beta blocker. And one more thing is Nebivolol. So Nebivolol, the special properties is, so it enhances the release of nitric oxide. It enhances the release of nitric oxide, and thus, because nitric oxide is a vasodilator, it causes vasodilation. That's why, and this is also beta 1 selective. Okay, that's why this Nebivolol and Carvedilol both are vasodilatory beta blockers. Remember, in the pathophysiology of hypertension, we have discussed that there is reduced production of nitric oxide. So this Nebivolol enhances the production of nitric oxide and thus causes vasodilation. So this Carvedilol and Nebivolol are vasodilatory beta blockers. That's you should remember. Okay, the difference is what is the difference in between these two? So this has short half-life, you should give in BD dose, and this has long half-life, you should give in OD dose, Nebivolol. That is the difference. Okay, so let us discuss now one by one. Metoprolol. So special properties: beta 1 selective. I will just zoom it. Beta 1 selective, long acting. Okay, succinate derivative. This succinate derivative is long acting. Tartarate derivative is short acting. So that's why that this tartarate, metoprolol tartarate, is used in extended release form, whereas succinate can be used in once daily form. So beta 1 selective beta blocker, succinate derivative is long acting, which is used in heart failure and hypertension, whereas the tartarate derivative is short acting. So this is used in angina and atrial fibrillation. So short acting one is used in angina and atrial fibrillation, whereas the long acting one is used in hypertension and heart failure. Succinate in hypertension and heart failure, tartrate in angina and atrial fibrillation. So indications: so reduced ejection fraction heart failure, succinate derivative will use. Okay, so same for post MI patients, angina patients, hypertension in the young, high renin hypertension, post MI. Okay, atrial arrhythmias. So these things are the indications. So heart failure with reduced ejection fraction, hypertension, angina, post MI, arrhythmias. So how many uses? So number one is heart failure with reduced ejection fraction. This is the number one thing. Number two is post MI. Okay, it reduces the hospitalizations and decreases the morbidity and mortality. Number three is angina. You can use stable angina. Okay, number four you can use in arrhythmias. So these are the uses of this metoprolol. Okay, after MI, in patients with heart failure with reduced injection of HF, angina and arrhythmias. What are the contraindications? So decompensated acute heart failure is a contraindications. Any beta blocker you shouldn't use in decompensated acute heart failure, meaning patient is in acute heart failure and he is having symptoms of that. so you should not use beta blocker. Cardiogenic shock is also a contraindication. So when you have shock, BP less than 90, you should not use beta blocker. Bradycardia is a contraindication. Advanced heart block, AV blocks, is a contraindication. Severe asthma is a relative contraindication. So, but cardioselective beta blockers you can use in asthma. Okay, it is a really contraindication. Main contraindications are decompensated acute heart failure, shock patients, bradycardia patients, blocks patients. So, what is the dose? Dose is 25 to 200 mg, 25 mg to 200 mg in hypertension, and up to 200 mg in heart failure patients. Up to 200 mg in heart failure patients. So what can be the side effects of this metoprolol? So they will cause breathlessness in excessive dose. Remember this point. They can cause breathlessness, especially in patients with COPD and asthma. Even though they have cardioselective property, they can cause breathlessness and COPD. Okay, this is one important side effect which we should remember. Okay, so the succinate derivative is used in heart failure and hypertensive patients, which is long acting, and tartarate derivative is used in angina and arrhythmia patients. Bisoprolol is a highly beta 1 selective blocker, and it has both renal and hepatic elimination. So remember this one. This is a first line beta blocker for stage 2 HFrEF. Remember the stages of heart failure: stage 1, 2, 3, 4. What is 1? Patient has the risk but no structural or functional abnormalities. Stage 2, risk factors with structural and functional abnormalities. Stage 3, risk factors plus structural and functional abnormalities plus symptoms. Stage 4 is resistant heart failure. So stage 2, so before development of the symptoms. So this is the first line for HFrEF and hypertension also. So remember this point. Even though metoprolol is used very much commonly, but bisoprolol is very much highly selective beta blocker. So this can be used, and this is the first line beta blocker for heart failure patient with reduced ejection fraction. Contraindication is same as metoprolol. Dose is 2.5 mg to 10 mg, usually used as OD dose. Usually 5 mg OD it is used. Sorry. So 5 mg OD dose is usually 5 mg OD dose is usually used. Okay. 5 mg to 10 mg you can use. 2.5 to 10 mg beta 1. So it is a very much okay. This is the modern guidelines which say to use bisoprolol, but in India metoprolol is very much commonly used and carvedilol is used. Still this bisoprolol are coming up. The physicians are coming up with the use of bisoprolol and nebivolol. They are not much used. Still metoprolol and carvedilol are more commonly used. I need to reduce the thickness of this. Okay. Then coming to the Carvedilol. So it is non-selective beta blocker plus alpha-1 blockade. That's I said no, alpha-1 and beta blockade. I said beta 1, but it is beta non-selective beta blocker plus alpha-1 blocker. One more important special property is it has antioxidant properties. It has antioxidant properties. So these two trials, Copernicus trial and Capricorn trial, so favor the use of carvedilol in heart failure with reduced ejection fraction. You can also use in hypertension, especially with metabolic syndrome. So this is because it has antioxidant properties. So this is very much favorable in patients with metabolic syndrome like diabetes mellitus, dyslipidemia, obesity, hyperuricemia. These are all components of metabolic syndrome. Okay. So all of them have the same contraindications: acute decompensated heart failure, AV blocks, bradycardia, shock. So in these things, you should not use this beta blocker. So important properties: antioxidant properties, vasodilators beta blocker with antioxidant. So metabolic syndrome. So I think this is very good beta blocker that can be used in patients with heart failure, having diabetes mellitus, hypertension, dyslipidemia because of its antioxidant properties. So usually the dose is 6.25 mg to 50 up to 50 mg you can use. Okay, the target dosage which is given in heart failure in Oxford, it is 12.5 mg BD should be the target dose. Starting dose is 3.125 mg BD. This is the starting dose. Okay, target dose 12.5 mg BD, totally 25 mg, and starting dose 3.125 mg BD. and target heart rate should be between 50 to 60. That is about the heart failure, which is already discussed in the heart failure section. You can go and watch that video. So Carvedilol is a very good beta blocker, okay, because of its vasodilatory and antioxidant properties. Okay, when you should use? So patient diabetes, mellitus, obesity, dyslipidemia, hypertension. I mean heart failure with metabolic syndrome patients, you can use this Carvedilol. Okay. So Nebivolol, beta 1 selective, I said no, nitric oxide mediated vasodilation. This is special body of the Nebivolol. So maybe better tolerated in elderly patients. So hypertension it is used. Possible role in heart failure with preserved ejection fraction. Okay. So these two, Bisoprolol and Carvedilol, in reduced ejection fraction, whereas Nebivolol in preserved ejection fraction, it can have a role. Contraindications are same. Starting dose is 5 mg. Up to 20 mg you can give. Okay. 5 to 20 mg. The last one is Atenolol. So this is also beta 1 selective. It is hydrophilic, renally excreted, less favored, weaker outcome data. So Atenolol nowadays not used. So same as Metoprolol indications. What are the indications of heart failure, hypertension, angina, and arrhythmias? Dose should be adjusted in patients with renal failure patients. This is important point because it has excretion through the exclusive through the kidney. You should adjust the dose in renal failure. Adjust the dose in renal failure. So contraindication is same, but one additional thing is Atenolol. You should think CKD patients you come. So there you should reduce the dose of this Atenolol because it is excreted through kidney only. So the dosage is 25 to 100 mg. Okay, you can see this 25 to 100 mg. OD dosage is given. Okay. So favorite beta, I will label some good beta blockers to use. Good beta blockers to use. Which are those? The good beta blockers are Bisoprolol, Carvedilol. These two are, and this is a rank 1. These two are rank 1. No, so I will give the rank, okay, based on the properties. This is rank 1 beta blocker, this is rank 2 beta blocker, this is rank 3 beta blocker, and these are rank 4. This is rank 4, I will say, and this is rank 5. If I want to rank this beta blocker, I will rank like this. So Carvedilol is rank 1 beta blocker, and Bisoprolol is rank 2 beta blocker. Nebivolol is rank 3 beta blocker. Metoprolol is rank 4 beta blocker. Atenolol is rank 5 beta blocker. Okay. Where else you can use Atenolol? You can use in patients with hyperthyroidism. So if propranolol cannot be used, instead of propranolol you can use it hyperthyroidism. You can use in migraine prophylaxis. Patient with hypertension, migraine, you can use this. Okay. Okay. So that's all about beta blockers. Favorite beta blockers: Carvedilol, Bisoprolol, Nebivolol. Okay. Let's move on forwards. So next thing is Alpha-1 blockers. So prazosin, Doxazosin, terazosin. These are the 3 Alpha-1 blockers. So Alpha-1, you remember, it causes vasoconstriction. Okay. So Alpha-1 blockers will cause vasodilation. So by causing vasodilation, they will decrease the BP. Okay. So first learn about Doxazosin. Okay. So special properties. It can have all these Alpha-1 blockers. They are given at night to reduce the risk of first dose syncope. Reduce the risk of first dose. You give the first dose, the patient can collapse. That is known as first dose syncope. So risk of first dose syncope, but improves lipids and insulin sensitivity. So this favors its use in patient with diabetes mellitus, CKD, hypertension, dyslipidemia. So like these drugs we need, no? Okay, but we need to consider the patient characteristics also. Economy, cheaper, whether the patient is economically good or not, everything matters. Okay, so one important point is it improves the lipids and insulin sensitivity. No heart failure outcome benefit. All heart trial. Okay, so one important thing in this doxazosin is, which is not seen in other thing, is it improves the lipids and insulin sensitivity. Similarly, terazosin also has that property. It improves the lipids and insulin sensitivity. Okay. Okay. What is prazosin? It is short acting. So these are long acting, but prazosin is short acting. So it requires triple dosing, or nowadays extended release forms are available, so you can give once daily at night time this extended release form. Okay, so what are the indications? Benign prostatic hypertrophy with hypertension. Why? Because in prostate the alpha-1 what do you call receptors are responsible. uh, Alpha-1 receptors are responsible for that what do you call prostate. What it does, it will compress the urethra. It compresses the urethra. So alpha-1 receptors are situated on the prostate. So when you give doxazosin or terazosin or prazosin, something like that, so that will act on this and that will relax the prostate, and thus improving the urine outflow, so any patient with who is having bph with hypertension or uh, resistant hypertension, as an add-on therapy you can give this doxazosin, okay, or terazosin also. Prazosin same as doxazosin. One important use of prazosin is it is short acting. Okay, so it is also used in post-traumatic stress disorder nightmares. So these patients with post-traumatic stress disorder, what they have at night time, they have bad what do you call memories in their dreams, bad dreams. So they have bad dreams. So those bad dreams can be prevented by this prazosin, can prevented by this prazosin. So it is used in the dose, not 5 mg dose, 1 mg up to 2 mg dose at night time. It is used to reduce the risk of nightmares in patient with chronic post-traumatic stress disorder. Okay, that is one special use of prazosin 1 to 2 mg. And also one more use is you use this in scorpion poisoning. Remember, you use this in scorpion sting. Okay, a victim of scorpion sting, you use this prazosin. Okay. Terazosin similarly be a benign prostate hypertrophy with hypertension. So one important use of prazosin is PTSD nightmares. Doxazosin improves lipid and insulin sensitivity. Okay. So what are the important contraindications? Let's see the important contraindications. So orthostatic hypertension is the most common contraindication of alpha-1 blockers. Gastric obstruction, this is also an important contraindication. Okay, so a patient who is having orthostatic hypertension, you should not prescribe doxazosin because they cause vasodilation, they will aggravate the thing, orthostatic hypertension. Mainly this is seen in elderly patients or those patients who are on tricyclic antidepressants, or diuretics, all those drugs which cause orthostatic hypertension. If you give this drug along with these drugs which cause orthostatic hypertension, that will aggravate the problem. So in gastric obstruction, you should not use uh, this doxazosin. So same contradiction to all doxazosin, prazosin, or terazosin. Uh, orthostatic hypertension, gastric obstruction. Okay. Typical oral dosage ranges: start low, go slow. That is the thing which we use. That is a mnemonic. Remember this. This will help in many things. Start low, go slow. Anything, any drug like insulin or anti-diabetic drugs or antihypertensive drugs. So you should start with slow dose and slowly you should increment the dose depending upon the patient's response. Start low, go slow. Okay. So doxazosin dose 1 mg to 16 mg per day. Prazosin is divided 1 to 20 mg. Terazosin also 1 to 20 mg. More commonly used is doxazosin 1 to 16 mg, and prazosin 1 to 20 mg should be divided thrice daily. Okay, that's about alpha-1 blockers. Now some centrally acting in the central nervous system. Okay, so which are those antihypertensives which are used and which act centrally? So first one is clonidine, as you know. So it is alpha-2 agonist. So I said if this is a neuron, okay, and this is a synapse. Sorry, I will draw it properly. I have discussed this thing. This is the synapse. Okay, so alpha-1 receptors are situated post-synaptically, whereas alpha-2 receptors are situated here. So this neuron will give epinephrine and norepinephrine. Okay, so when this alpha-2 is presynaptic alpha-2 receptor is stimulated, the release of epinephrine and norepinephrine is decreased, so thus decreasing the sympathetic outflow and thus decreasing the blood pressure. But if you stimulate this alpha-1 receptor, so that will increase the BP. Okay, So that's how this centrally acting alpha-2 agonist, these are not antagonist, okay, agonist. So agonistic activity will decrease the release of epinephrine and norepinephrine. So that's the mechanism. So alpha-2 agonist, it can be used as a patch weekly, available as weekly. This is important point. Rebound hypertension withdrawal, and this is also an important point in beta blockers also, which is not mentioned there. So beta blockers you should not stop abruptly, because there is a chance of rebound hypertension. Patient will have increased BP after abrupt cessation of these drugs. So similar to this central acting agents, beta blockers should not be uh, stopped abruptly. So rebound hypertension withdrawal. So where you can use in as an add-on to resistant hypertension. And remember this one psychiatric use here. Attention deficit hyperkinetic disorder. Attention deficit hyperkinetic disorder you can use. You can use in opioid withdrawal also. Opioid withdrawal. And one more thing, you can use in migraine prophylaxis also. Migraine prophylaxis. Okay. Important. So these are the things. Resistant hypertension and resistant hypertension, ADHD, attention deficit hyperkinetic disorder, opioid withdrawal. Opioid withdrawal you can use clonidine. Opioid withdrawal you can use clonidine. Okay. So contraindication, do not abruptly discontinue this drug. So orally you can use at a dose of 0.1 to 0.6 mg. You have to give it in TID dose, remember, okay, or BD dose. 0.1 to 0.6, 0.1 to 0.6 orally. Patch 0.1 to 0.3 mg per week. So clonidine patch is available 0.1 to 0.6, 0.3 mg per week. Okay. Coming to the next drug, Methyldopa. So this is a drug of choice in pregnancy, but this is not used frequently. Labetalol is used. Central and peripheral, both it has both central and peripheral effects. So hypertension in pregnancy induced hypertension is used with Methyldopa. But the important contraindications, acute liver disease like hepatitis, cirrhosis, depression is also a contraindication for the use of Methyldopa. What is the dose? 25 to 2000 mg in divided doses. So you should give in TID dose Methyldopa. Starting dose is 250 mg. You can go up to 2000 mg. 2000 mg. Important contraindication, liver disease, maybe cirrhosis or hepatitis. And depression is also a contraindication to Methyldopa. So among these three, the most commonly used drug which acts centrally is Moxonidine, brother of clonidine, Moxonidine. But the site of action is different. It is an imidazolin receptor agonist, selective imidazolin receptor agonist. So less sedation and dry mouth. So with clonidine you will have sedation and dry mouth with the use of clonidine, but you have less sedation and dry mouth with this Moxonidine when compared to clonidine. And this is also an important one. It improves insulin sensitivity. So most of the patients who have hypertension, they have this metabolic problem. So we should choose those drugs which have this metabolic metabolic controlling power of metabolic syndrome. Okay, so that's why Moxonidine has improved insulin sensitivity. So where you use in resistant hypertension, you use it. So all these drugs are used in this one, resistant hypertension. Alpha-1 blockers also resistant hypertension, but some other users that are also there, like prazosin in PTSD nightmares you can use, and in a scorpion sting. Okay, clonidine you can use in opioid withdrawal. Okay, opioid withdrawal, that's one. Attention deficit ADHD you can use. Okay, so Moxonidine, resistant hypertension, metabolic syndrome, obesity, diabetes, especially in these patients. But what are the side effects of Moxonidine? Severe bradycardia. So in patients with bradycardia, you shouldn't use this Moxonidine. Patients with AV block, patients with heart failure, concomitant MAO inhibitors, salaginine, rasaginine. These are salagilin and rasaginine. So these are MAO inhibitors. Okay. So Moxonidine contraindications are similar to contraindications of beta blockers. So because it causes bradycardia, that's why Moxonidine should not be used in patients with acute heart failure, bradycardia, and AV blocks. AV blocks. The dose is usually 0.2 to 0.6 mg in divided doses. So usually BD dose it is used. You can use even OD dose also, but if patient is still hypertensive, you can use in BD dose also. Usually 0.3 mg OD start with 0.3 mg OD. You can give 0.3 BD, 0.3 mg BD. Okay. So you shouldn't give in patients with bradycardia, AV blocks, heart failure. This one, Moxonidine. Okay, these are the agents which can be used in heart failure patients. So Labetalol, I think we have not discussed in beta blockers. Remember this Labetalol. I will just so Labetalol is similar to this Carvedilol. Similar to the Carvedilol, Labetalol is also a alpha beta blocker, but the blocking of alpha beta is 1:7 ratio. 1:7. Okay, 1:7. 1:7. So I think beta blocking is 1 and alpha blocking is 7, like this. So Labetalol is the drug of choice. Drug of choice in most of the hypertensive emergencies. Labetalol is the drug of choice in most of the hypertensive emergencies, most of the choice, except in patients like heart failure. You should not use. There the drug of choice is nitrates, IV nitrates, so which reduces the preload, afterload, and BP all. So IV nitrates are the drug of choice in heart failure patients. Rest thing in almost all of the hypertension emergencies, Labetalol is nowadays the drug of choice. Next to Labetalol is nicardipine IV, calcium channel blocker, nicardipine, cerebroprotective. Okay, so Labetalol is used in Methyldopa is not used, but Labetalol and nicardipine are more commonly used in pregnancy with hypertension. So the next drugs are Hydralazine, Vasodilators, directly acting vasodilators. Okay, direct Hydralazine and Minoxidil, two things. Okay, so Hydralazine, direct arteriolar dilator. So that's why it causes reflex tachycardia and fluid retention. So use with beta blocker plus diuretic. Why? Why you should use with beta blocker and diuretic this Hydralazine? Because it causes reflex tachycardia. It causes, and this is also a drug which is used in hypertensive emergency. Remember, hypertensive emergency. But you should use because it causes tachycardia, and second, fluid retention it can cause. Fluid retention it can cause. So to counter that, what you will do, you give beta blocker to counter this one and diuretic to counter this one. So Hydralazine should be used along with a beta blocker and diuretic to counter the side effects. So one important thing is there is a risk of drug-induced lupus with the use of this drug, Hydralazine. Drug-induced lupus. Drug-induced lupus. Okay. There is something called as autoimmune lupus, systemic lupus erythematosus. Okay. There is something called as, there is another thing which is called as drug-induced lupus. So one among the drug is Hydralazine. So Hydralazine should be used along with a beta blocker and diuretic. So where it is used, hypertension in pregnancy, you can use this Hydralazine. Reduced ejection fraction heart failure in African Americans with isosorbide dinitrate. Okay, severe hypertension, IV available. So I said no, in hypertension emergencies you can use. You can use in patients with reduced ejection fraction, okay, with isosorbide dinitrate and hypertension. So 3 uses. Hypertension pregnancy is the one use. Okay. Second thing is HFrEF along with nitrates. Okay. The third thing is severe hypertension. You can give, but remember when you give, you should give with beta blocker and diuretic. Okay, that's all about this one. Key indications. The next thing is important contraindications. You should not use in coronary artery disease. Why? There is something called as coronary steal phenomena. Can you remember this coronary steal phenomena? So that you go and just watch, type this coronary steal phenomena, read in the book. You will know that. So this will happen and this will aggravate the angina. So you shouldn't use with in patients with coronary artery disease. Aortic dissection you should not use because there is a risk of tachycardia. No, that's why you should not use in aortic dissection. You should not use it in patients with systemic lupus erythematosus. Systemic lupus erythematosus because it has a risk of drug-induced lupus. Dosage is 25 to 100 mg in divided doses. 25 to 100 mg in divided doses. Not commonly used. Not commonly used. Okay. Minoxidil is extremely potent, causes severe hirsutism, excessive body hair growth, and fluid retention. Reserved for refractory cases. Reserved for refractory. Minoxidil is reserved for refractory cases. it body growth. So you know this is used as 5% and 10% topical hair oil in patients who are having alopecia, androgenetic alopecia. There it is used. Okay, but this is also used in cases where refractory cases of hypertension. So severe resistant hypertension along with a beta blocker, loop diuretic and a beta blocker you should use because it causes fluid retention similar to hydralazine. So both these drugs, hydralazine, minoxidil, should be used with a beta blocker and diuretic. Contraindications are pheochromocytoma, acute myocardial infarction because of coronary steal phenomena. So remember, any uh, coronary artery disease condition, it can range from angina to acute MI. So you should not use these drugs because of coronary risk of coronary steal phenomena. So dosage is 2.5 to 100 mg. So that's all about the antihypertensive drugs. Okay, we have discussed all about the antihypertensive drugs, almost all. Maybe I missed some drugs. So we will continue other topics like resistant hypertension, what is hypertension, crisis, urgency, emergency, acute hypertension, and the drugs which are used, how to use. Okay, thank you for listening.